Have you ever looked at a textbook page on the gastrointestinal system and just thought, wow, I need like a secret superpower to really untangle all this complexity?
Oh, absolutely. You're definitely not alone there.
Well, today we're diving deep into exactly that. We want to help you master one of the body's most intricate and vital systems.
Indeed, the GI system, our digestive powerhouse, it's just fundamental to life. It handles our nutrition, waste elimination. But it's so much more than just a tube.
Right.
It's a really precisely choreographed symphony of organs, nerves, biochemical processes, everything working together.
And that's why for you nursing students, truly getting the system isn't just about memorizing facts, is it?
Not at all.
It's really about understanding the why behind the what, so you can provide truly excellent, informed patient care.
Exactly.
So our mission today is to take a stack of, let's be honest, dense medical surgical nursing content, straight from Lewis's medical surgical nursing, and just pull out the most important nuggets of knowledge for you.
Yeah. We'll be your guides. We'll walk you through the structures, the functions, how to assess, normal versus abnormal findings, the latest diagnostic tests, and really importantly, your crucial role in nursing management.
Think of it as your shortcut, maybe, to being well-informed.
Hopefully with practical insights and maybe a few aha moments that actually stick with you.
Okay, let's kick things off. Laying the groundwork, exploring the amazing structures and functions, starting right at the beginning of that digestive journey.
Sounds good.
So this incredible journey, mouth to anus, it spans about 30 feet, but it's far from just a simple pipe. What makes it so complex structurally?
It really is a marvel of engineering. The GI tract is built in 4 really sophisticated layers. You've got the inner mucosa lining,
Okay.
then the submucosa, which is rich with connective tissue, glands, blood vessels, lymph nodes, then a pretty robust muscle layer, and finally the outer serosa.
And that muscle layer isn't simple either, right?
Not at all. Within that muscle layer, you actually have 3 distinct smooth muscle layers: oblique, circular, and longitudinal, all working in this precise concert for movement, for peristalsis.
And it essentially has its own dedicated nervous system, doesn't it? It's its own brain, kind of.
You could definitely say
Yeah.
that. You're absolutely right. Beyond the input it gets from the autonomic nervous system.
Mm-hmm.
Parasympathetic speeds things up, sympathetic slows it down.
Mm-hmm.
The GI tract has its own independent nervous system, the enteric nervous system, or ENS.
The second brain.
Exactly, people call it that. And what's fascinating is it can actually function independently of the brain and spinal cord. It controls gut movements, secretions, locally.
That's a really key insight for nurses, isn't it? Understanding that local gut issues aren't always coming from the brain.
Precisely. It helps you think about where the problem might originate.
What about the circulation? I heard it's not just straightforward blood flow to the organs.
No, it's quite unique, actually,
Yeah.
and really fascinating. Venous blood from the GI organs doesn't just return straight to the heart. It first drains into the portal vein, and that vein perfuses the liver.
Ah, so the liver gets first dibs.
Exactly. It acts as this crucial gatekeeper. It cleans the blood of bacteria, toxins from the GI tract before it gets into the general circulation.
Wow.
Yeah. Then the arterial blood comes from specialized arteries, celiac, superior mesenteric,
Yeah.
inferior mesenteric, each supplying different sections. And the GI system, it demands a significant chunk of your cardiac output,
How much?
like 25% to 30% at rest, even more after you eat. It just highlights how critical its metabolic role is.
And then there's the peritoneum. You mentioned it acting like a protective apron.
Yeah, that's a perfect image for it. The peritoneum, with its parietal and visceral layers, it almost completely covers the abdominal organs.
Mm.
And its folds, like the mesentery and omentum, they provide attachment, they contain vital vessels, they even hold fat and lymph nodes. So it offers both support and defense.
So at its core,
Mm.
after all that complexity, what's this entire elaborate system ultimately trying to achieve for the body?
Well, fundamentally, its main job is to supply nutrients to our body cells.
Mm-hmm.
Simple goal, complex process.
Right.
And it does this through 4 basic but beautifully coordinated processes.
Mm.
Ingestion, taking food in.
Okay.
Digestion, breaking it down mechanically and chemically. Absorption, getting those broken down products into the bloodstream. And finally, elimination, getting rid of the waste.
Let's trace that journey then, starting with ingestion. It's definitely more than just putting food in your mouth.
Absolutely. Ingestion involves appetite,
Mm.
influenced by hormones like ghrelin, which stimulates it, and leptin, which suppresses it.
Mm-hmm.
Even just the sight, smell, taste of food
Mm-hmm.
that gets the process going. Then you have deglutition, fancy word for swallowing.
Right.
Involves the mouth, pharynx, esophagus, and critically, you have to remember the epiglottis closing over the larynx. That prevents aspiration.
Super important safety point for
It's
patients.
vital, absolutely vital.
And the esophagus has that really important barrier at the bottom, right?
Right.
The LES.
Crucial, especially for preventing complications like reflux. The lower esophageal sphincter, or LES, at the distal end, it normally stays contracted, tightly closed.
Except when?
Except during swallowing, belching, or vomiting. Otherwise, it's this vital barrier stopping acidic stomach contents from splashing back up into the esophagus.
And if that fails?
Heartburn, GE or D, potentially esophagitis.
Yeah.
A dysfunctional LES is a common issue.
Okay, so the food hits the stomach, which acts as what? A storage unit and a mixer, preparing things.
Precisely. The stomach stores food, mixes it with gastric secretions, forming this paste called chyme, and then it empties contents slowly into the small intestine.
And it produces some key things, too.
Oh, yeah. It makes pepsinogen, which becomes pepsin for protein digestion. But for you as nurses, two crucial secretions are hydrochloric acid.
Kills bugs.
Kills ingested organisms, exactly. And intrinsic factor. Intrinsic factor is absolutely essential for vitamin B12 absorption later on, down in the small intestine.
Without it.
Patients can develop pernicious anemia. That's a key nursing consideration you need to look out for, especially in certain patient populations.
Got it. Then comes the small intestine. This is where the real magic of breaking down nutrients and absorbing them happens.
Mostly, yes. That's where the bulk of it occurs. This coiled tube, it's about 23 feet long.
Wow.
And it's lined with villi and microvilli. These tiny finger-like projections just dramatically increase the surface area.
Like a massive filter and uptake system.
Exactly. Incredibly efficient. It breaks down carbs, fats, proteins into their absorbable forms. Monosaccharides, amino acids, fatty acids. And it's all exquisitely coordinated. Neural controls, hormonal controls, constantly at play, stimulating or inhibiting digestion as needed.
Okay, finally. Elimination. The end of the line, but still vital for overall health.
Absolutely. The large intestine, maybe 5 to 6 feet long, its main focus is absorbing water and electrolytes, forming feces, and acting as a reservoir until defecation.
And it does more than just that, right? I heard about vitamins.
Yeah, interesting fact. The microorganisms living in your colon, your gut microbiome, they actually produce vitamin K and some B vitamins that your body uses.
Huh.
They also break down proteins that weren't digested earlier. And, they produce gas or flatulence as a byproduct of their metabolism.
Right. And defecation itself,
Right.
it's a reflex, but it can be tricky sometimes.
It is. It involves both voluntary and involuntary control. When feces enter the rectum, it stimulates nerve endings, creating the urge.
Okay.
Now, the Valsalva maneuver, bearing down, basically holding your breath and straining, it can help expel stool.
But nurses need to be careful with that one.
Very careful. Acutely aware of its contraindications. It temporarily increases pressure inside the abdomen and chest.
Which is risky for?
Risky for patients with head injuries, recent eye surgery, heart problems, severe hemorrhoids, recent abdominal surgery, or liver cirrhosis with portal hypertension. You really need to know who's at risk from this seemingly simple action.
That's a crucial takeaway. Okay, beyond the tract itself, we have those vital accessory organs. Let's talk liver first. Biggest internal organ, right? A metabolic powerhouse.
Exactly. Weighs about 3 pounds. It has metabolic, secretory, vascular, storage functions. It does so much. Its functional units, the lobules, have hepatocytes and these specialized cells called Kupffer cells.
What do they do?
They're phagocytes. They hang out in the liver sinusoids and gobble up bacteria and toxins from that portal blood we talked about. Another critical filtering step.
And bioproduction.
Yeah.
Key for digestion, but it also handles waste products like bilirubin.
Absolutely. The liver's constantly making bile, which is essential for emulsifying and digesting fats. And yes, it processes bilirubin, that pigment from hemoglobin breakdown.
How does that work?
Well, it converts insoluble bilirubin, which needs albumin to travel in the blood, into a water-soluble form. That conjugated bilirubin can then be excreted in bile. It eventually gets broken down by bacteria in the gut to stercobilinogen.
Which makes stool brown.
Exactly. Gives stool its characteristic color. And when this whole bilirubin pathway goes wrong, that's often one of our first visible clues, like jaundice, indicating liver problems.
Okay. Then we have two other critical partners, the gallbladder and the pancreas. What are their key roles?
The gallbladder is this little pear-shaped sac tucked under the liver. Its job is basically to concentrate and store bile.
And it releases it when?
It releases bile into the small intestine when fatty foods arrive, triggered by a hormone called cholecystokinin, or CCK.
Okay. And the pancreas?
The pancreas lies behind the stomach. It has dual functions, really important ones. Exocrine function, producing powerful digestive enzymes like amylase for carbs, lipase for fats, trypsinogen for proteins,
Mm-hmm.
and endocrine function. Its islets of Langerhans secrete hormones directly into the blood, like insulin and glucagon, which are absolutely crucial for regulating blood sugar.
Okay, so we've covered the amazing intricacies of the GI system when it's working well, but what happens as we age? How does it change? And what does that mean for our nursing assessment?
That is such a critical question for nursing students. How do we tell the difference between normal aging and actual disease? It's not always obvious.
Right.
For instance, many older adults experience a decrease in appetite. Eating just becomes less pleasurable,
Why is that?
often due to multiple factors. The number of taste buds declines, the sense of smell lessens, xerostomia, that's dry mouth from less saliva, becomes common. All these can contribute to poor nutrition if you're not watching for it.
So it's not just about the physical act of eating, but the whole experience changes too.
Precisely. And in the esophagus, older adults might have delayed emptying. Why? Because of smooth muscle weakness? Maybe the upper esophageal sphincter doesn't open as well? The lower one might be less competent.
Increasing risk for reflux or aspiration.
Exactly. Increased risk for both. Now, while GI motility generally slows down a bit, secretion and absorption are surprisingly less affected than you might think.
Okay, and what about things like stomach acid and common complaints like constipation?
Yeah, older adults often have a decrease in intrinsic factor and hydrochloric acid secretion. It's a condition called hypochlorhydria.
Affecting B12 absorption again.
Right back to that. And chronic constipation is a really significant issue.
Yeah.
Affects like 30% to 40% of adults over 60.
Wow. What causes that?
It's usually multifactorial. Slower peristalsis, maybe some anorectal dysfunction, definitely inactivity, decreased fiber and fluid intake, and certain medications. Polypharmacy is a big player here.
Mm-hmm. And the bigger organs, liver, pancreas, do they change?
The liver's size actually decreases after age 50. And while standard liver function tests, your LFTs, often stay normal, age-related enzyme changes can decrease the liver's ability to metabolize drugs and hormones.
Which means?
Significant implications for nursing. Medication dosages often need adjustment in older adults. You have to be really mindful of potential toxicity.
Okay.
The pancreas also undergoes structural changes, fibrosis, fatty deposits, and gallbladder diseases like gallstones tend to increase with age too.
So when we're assessing an older adult, we're not just hunting for disease. We also need to recognize these expected age-related changes because they seriously influence their health and our care.
Absolutely. And this raises an important question for you, the listener. Knowing these differences, how are you going to individualize your assessment?
Good question.
For instance, you might find an older adult's abdomen is thinner, less taut. Palpating organs might actually be easier. Or you might see peristalsis more visibly, which could be normal for a thin, older person, but a big red flag in someone younger.
And pain perception might change too.
Yeah, less sensitivity to surface pain is also something critical to consider. They might not present with classic pain symptoms, even with serious issues.
Okay, now that we've got the basics and the age-related stuff down, it's time for the detective work.
Correct.
How do we actually assess the GI system effectively? What subjective and objective data do we need to get that full picture?
Right, the assessment process. It's paramount for catching problems early. We always start with subjective data, what the patient tells us.
The health history.
A thorough health history. Asking about any abdominal pain, nausea, vomiting, distension, jaundice, heartburn, changes in appetite. The works. We need to know about their bowel habits, frequency, consistency, any diarrhea, constipation, melena.
Those black tarry stools.
Exactly, indicating upper GI bleeding. Or any bright red rectal bleeding. Even subtle clues like unexplained weight loss or gain over the last 6 to 12 months are highly significant flags.
Medications and past surgeries must be huge pieces of the puzzle too.
Crucial, yeah. So many medications have GI side effects. And conversely, GI problems can mess with drug absorption.
So you need to ask about everything.
Everything. Current and past use, including over-the-counters like antacids or laxatives, people often forget to mention. We specifically look for hepatotoxic drugs, things like chronic high doses of acetaminophen, NSAIDs, and antibiotics, which can wipe out normal gut flora, causing diarrhea, like C. diff, liturgical history, of course. And appendectomy, a cholecystectomy, provides vital context for their current presentation.
You also mentioned looking at functional health patterns. What does that involve? It sounds holistic.
It is. It's about integrating lifestyle. So, for example, the health perception, health management pattern. We'd ask about habits like smoking, alcohol intake,
Mm,
known irritants, risk factors for GI cancers, liver damage.
makes sense.
We'd also ask about foreign travel, thinking about hepatitis, parasites. Family history is huge, too. Colorectal cancer, inflammatory bowel disease. Genetics play a big role.
Yeah, nutrition.
The nutritional metabolic pattern involves a detailed diet history. Food allergies, fluid intake, fiber intake. This is also where we'd explore food preferences influenced by culture or religion. It's
Yeah.
all part of seeing the whole person.
Right, let's try to apply this. We have a case study.
Hmm.
LC, a 58-year-old Native American man, he comes in with severe abdominal pain.
Okay.
Subjectively, he tells us he hasn't felt well for weeks. He's got weakness, fatigue. He smokes a pack a day, has for 20 years, drinks 3-4 beers daily. He's been losing weight without trying, no appetite, and he reports alternating constipation and diarrhea with bright red blood in his stools recently.
Okay. Red flags already.
He rates his pain right now as a 9 out of 10, prefers to lie still with his knees flexed, hasn't had a bowel movement in 4 days. What are the major things jumping out at you from just that subjective report? What might they suggest?
Okay. For you, the listener, think about LC. Which of those findings concern you most? For me,
Well, the chronic smoking and alcohol use are significant long-term risk factors, definitely. But the acute picture, unexplained weight loss, fatigue, those altered bowel habits, and especially the bright red blood, those are immediate red flags. Suggest significant GI pathology, likely active bleeding somewhere low down.
and the pain.
His severe acute pain making him double over like that indicates an urgent situation. Could be inflammation, maybe obstruction. Something serious is happening right now.
Okay, now let's move to the objective data we can actually see, hear, feel. Physical assessment of the abdomen. It can seem intimidating. So much going on inside.
It doesn't have to be. Just remember the standard order.
Yeah.
Inspection, then auscultation, then percussion, and finally palpation. Auscultation before touching.
Always.
Yeah.
Because manipulating the abdomen, pressing around can alter bowel sounds, so you listen first.
Got it. How do we start?
Patient should be supine, knees slightly flexed to relax the muscles, ideally with an empty bladder. Warm hands are key. And have them take a slow, deep breath.
Yeah.
That helps relax the abdominal muscles too.
Okay, inspection. What are we looking for specifically?
We're looking at skin changes, color, scars, striae, rashes. The umbilicus is inverted, everted, symmetry of the abdomen. The contour is at flat, rounded, protuberant, scaphoid, distended. We note any observable hernias, any obvious masses. You might even see aortic pulsations in the epigastric area, especially in thinner people.
Then auscultation. Listening for.
Bowel sounds. Use the diaphragm of your stethoscope for these high-pitched sounds. Start in the right lower quadrant. Bowel sounds are normally always present there.
Do we count them?
No need to count them anymore. Just assess their character. Are they normal, sort of high-pitched, gurgling sounds every 5 to 15 seconds? Are they hypoactive, very quiet, infrequent? Or hyperactive, loud, rushing, borborygmi, like stomach growling?
What about abnormal sounds?
High-pitched rushes and tinkling sounds. Those can indicate an intestinal obstruction as the bowel tries to push contents through a narrow area. And always listen for vascular sounds or bruits using the bell. Bruits suggest turbulent blood flow, maybe an aneurysm or stenosis.
Okay. Then percussion. Tapping around. What does that tell us?
Percussion helps estimate the size of solid organs like the liver and spleen. It also helps detect fluid, distension, or masses.
How?
Air, which is usually predominant in the abdomen, produces a higher-pitched, hollow sound called tympany. Fluid or solid masses produce a dull sound, so you percuss over different areas. For the liver, you percuss down from the chest and up from the abdomen to find its upper and lower borders and estimate its size.
And finally, palpation. Feeling around. This needs to be done carefully, right?
Right. Very carefully. Always start with light palpation. Just gently pressing about maybe 1/2 inch, 1 centimeter.
Looking for?
Detecting tenderness, muscle resistance, or guarding any superficial swelling or masses. Then, if tolerated, move to deep palpation. Pressing more firmly to delineate deeper organs and masses, noting their location, size, shape, consistency.
And painful areas.
Always palpate areas of reported tenderness last. You don't want to cause unnecessary pain or guarding that obscures the rest of your exam.
What about rebound tenderness?
That's a critical finding. Pain occurring on the quick withdrawal of your fingers after pressing deeply. It indicates peritoneal inflammation, peritonitis. But listen, this should only be done by an experienced practitioner, usually a physician or NP, and only at the very end of the assessment. It can cause severe pain and potentially worsen things if not done correctly.
Okay. Good to know. How about specific organs, like the liver or spleen?
For the liver, you might try to feel its edge under the right costal margin as the patient takes a deep breath. It should feel firm, sharp, smooth. The spleen, however, is normally not palpable.
And if you feel
If
it.
you do feel an enlarged spleen, you should stop palpating immediately. Manual compression of an enlarged spleen, like in mono, can cause it to rupture. Very dangerous.
Right. And we can't forget the rectal and anal exam as part of a complete GI assessment.
Also vital, yes.
Mm.
For inspecting externally for lesions, hemorrhoids, fissures, masses, and then digitally assessing sphincter tone, checking for any irregularities inside the rectum, and often obtaining a stool sample to check for occult blood.
Though you said one test isn't definitive.
Correct. A single fecal occult blood test, like a guaiac test, has limited sensitivity for colorectal cancer screening, but it's still a useful piece of the puzzle, especially if positive.
Okay, let's bring it back to LC. His objective data: BP 12074, heart rate 110, respirations 24, temp 100.4 degrees over 38 degrees.
Okay, tachycardic and febrile.
His abdomen is firm and slightly distended. Auscultation reveals high-pitched bowel sounds in the upper quadrants, but no bowel sounds heard in the left lower quadrant.
Absent sounds in one quadrant. Significant.
Mild abdominal palpation elicits pain, and a rectal examination revealed a palpable mass. So what does this objective data combined with his history tell you now?
Okay, what jumps out at me now is that combination. He's got signs of systemic inflammation or infection, the tachycardia, the fever. He's got a firm, distended abdomen. The bowel sounds are altered, high-pitched rushes. Might suggest the bowel's trying hard to push past something.
An obstruction.
Possibly. And the absence of sounds in the left lower quadrant is really concerning. Could mean complete obstruction or ileus there. Combine that with a palpable rectal mass and his severe pain. This paints a very concerning picture.
Suggesting.
Strongly points towards a significant acute abdominal issue, likely an obstruction, possibly caused by or related to that rectal mass and the tumors suspected from his bleeding history. These are urgent findings needing immediate action.
Okay, so we've gathered our subjective and objective clues from LC. He's clearly got something serious going on. Now it's time to confirm suspicions and really see inside using diagnostic studies. For nursing students listening, it's not just knowing the name of the test, right? It's about understanding your role.
That's absolutely essential. Your role is critical. For most diagnostic studies, your responsibilities include things like ensuring informed consent is obtained and documented, thoroughly teaching the patient about the procedure, what to expect, why it's being done, asking about allergies.
Especially iodine or contrast.
Definitely. Iodine, contrast media, latex, shellfish. And managing the preparations. Is the patient NPO? Do they need bowel cleansing? What kind? And you always need special considerations for older adults. They might struggle more with prolonged fluid restriction or holding positions needed for tests.
Right. Let's start with some of the common radiologic studies, like the GI series.
Yeah, we have the upper GI series, or barium swallow. Patient drinks barium or maybe gastrographin, and x-rays track it moving through the esophagus, stomach, duodenum. Looks for strictures, polyps, ulcers, motility issues.
And the lower version.
Lower GI series, or barium enema. Barium is given via enema to visualize the colon. Again, looking for tumors, polyps, diverticula. Less common now with colonoscopy, but still used sometimes.
There's also virtual colonoscopy.
Right, using CT or MRI to create 3D images of the colon. Requires bowel cleansing, but no sedation needed. It can be good for patients who can't tolerate a full colonoscopy, maybe because of a narrow colon, though it might miss smaller polyps sometimes.
Makes sense. CT scans and MRIs are pretty standard now for detailed views, aren't they?
Absolutely. CT scans, especially with IV or oral contrast, are great for detecting biliary tract issues, liver problems, pancreatic disorders. Really good overview.
Contrast considerations.
Always check renal function before giving IV contrast. And assess for allergies. For MRI, it offers incredibly detailed images, especially for hepatobiliary disease or staging GI cancers, looking for spread. Big thing with MRI is ensuring no metal objects, implants, pacemakers, even some medication patches.
Okay. Ultrasound is common too.
Very common. Abdominal ultrasound is non-invasive, great for looking at gallbladder for stones or inflammation, checking for masses, fluid collections. And then there's endoscopic ultrasound, EUS.
What's that?
That's where an ultrasound transducer is put on the end of an endoscope. It gives highly accurate close-up images, especially useful for staging tumors, seeing how deep they've invaded the gut wall or nearby nodes.
And FibroScan.
That's a specialized type of ultrasound elastography. It measures liver stiffness, which helps assess the degree of liver fibrosis or scarring in chronic liver disease, like hepatitis C or fatty liver disease. Non-invasive way to monitor disease progression.
Okay, beyond just imaging, endoscopy lets us get that direct up-close look inside.
Right. Endoscopy means direct visualization using a flexible scope with a light and camera. Can examine esophagus, stomach, duodenum, EGD, or the colon, colonoscopy. Sigmoidoscopy just looks at the lower part of the colon.
Big risk with endoscopy.
Perforation, tearing a hole in the GI tract. It's rare, but serious. So careful post-procedure monitoring is crucial, watching for pain, fever, abdominal distension.
Okay. Colonoscopy specifically
Yeah.
visualizes the whole colon.
Yes, the entire colon, from rectum to cecum. Gold standard for detecting polyps, cancer, inflammatory bowel disease.
And the nursing role for colonoscopy prep and post-care.
Huge role.
Mm.
Includes ensuring the bowel prep is completed effectively, often a split-dose regimen now for better tolerance and cleansing, explaining what to expect post-procedure, maybe some cramping or gas, and vigilant monitoring afterwards for any rectal bleeding, severe abdominal pain, fever, signs of perforation like malaise or tenesmus.
Got it. An ERCP, that sounds pretty involved.
It is. Endoscopic retrograde cholangiopancreatography. An endoscope is passed down into the duodenum, then a catheter is threaded into the bile and pancreatic ducts. Contrast dye is injected and x-rays are taken.
Why do that?
To visualize the pancreatic ducts, hepatic ducts, common bile duct, looking for stones, strictures, tumors. And it can be therapeutic too. They can retrieve gallstones, dilate strictures, place stents, or get biopsies during ERCP.
Nursing priorities for ERCP.
Keeping the patient NPO beforehand, ensuring consent, administering sedation and monitoring during. And post-procedure, assessing carefully for complications. Perforation, infection. But the most common complication here is pancreatitis.
Pancreatitis, why?
Irritation or swelling of the pancreatic duct from the catheter or dye. So you watch closely for severe abdominal pain, nausea, vomiting, rising amylosylipase levels afterwards.
Okay. And EGD, upper endoscopy.
Esophagogastroduodenoscopy.
Yeah.
Directly visualizes the upper GI tract, esophagus, stomach, first part of the small intestine, duodenum, looking for inflammation, ulcers, tumors, varices.
Post-EGD pair.
Main thing is keeping the patient NPO until their gag reflex returns, because the throat is numbed for the scope. Also, monitor temperature closely. A spike could indicate perforation, and watch for any bleeding.
Capsule endoscopy. Sounds like science fiction.
Just pretty amazing technology. The patient swallows a vitamin-sized capsule that contains a tiny camera, light source, and transmitter.
Seriously?
Yeah. It takes thousands of pictures as it travels naturally through the entire GI tract, especially the small intestine, which is hard to reach otherwise. It relays the images to a recording device the patient wears.
Wow. Non-invasive way to see the small bowel.
Exactly. Really useful for finding sources of obscure GI bleeding or diagnosing Crohn's disease in the small bowel.
Okay, let's switch to blood tests. Liver function tests, LFTs, we hear about them constantly. What specifically are we looking for?
LFTs are a panel of blood tests that reflect different aspects of liver function or injury. We look at serum bilirubin total, direct, conjugated, indirect, unconjugated, to assess the liver's ability to handle bilirubin breakdown.
And enzymes, ALT, AST.
Right. Alanine aminotransferase, ALT, and aspartate aminotransferase, AST, are enzymes found inside liver cells. When liver cells are damaged, these enzymes leak out into the blood, so high levels indicate hepatocellular injury.
Others, ALP, GGT.
Alkaline phosphatase, ALP, and gamma-glutamyl transferase, GGT, are often elevated in biliary obstruction problems with bile flow, or sometimes with liver damage too.
And what about tests of liver function, like making things?
Good point. We look at albumin levels. Low albumin can indicate decreased liver synthetic function as the liver makes albumin. And prothrombin time, PT or INR, reflects the liver's ability to make clotting factors. If PT is prolonged, it suggests impaired liver function. Ammonia levels can also indicate the liver's ability to detoxify substances.
So knowing what these numbers mean gives us a powerful diagnostic lens as nurses.
Absolutely. They help pinpoint the type and severity of liver issues.
Finally, a liver biopsy. That sounds like a pretty big deal, and a critical nursing intervention surrounding it.
It is a significant procedure, yeah, because it involves getting an actual piece of liver tissue, needed to definitively diagnose things like liver cancer, or specific types of liver disease like cirrhosis, or to assess the degree of fibrosis or inflammation.
How's it done?
can be an open procedure during surgery, or more commonly, a closed or percutaneous needle biopsy, often guided by ultrasound or CT scan now for better accuracy and safety.
And the nursing management for that closed needle biopsy is critical.
Absolutely critical. Pre-procedure, making sure the patient is NPO, checking coagulation stat, PPINR, platelets, because bleeding is the major risk. Ensuring blood type and cross-match is done, just in case. Teaching the patient they'll need to hold their breath after exhaling when the needle is inserted to keep the liver still.
And post-procedure.
Vigilant monitoring. Vital signs frequently, like every 15 minutes initially, then every 30, then hourly. Watching closely for signs of internal bleeding, dropping BP, rising heart rate, abdominal pain, shoulder pain, or signs of pneumothorax if the needle went too high.
Positioning.
Key intervention. Keep the patient lying on the right side for at least 2 hours after the biopsy. This puts direct pressure on the puncture site to help stop bleeding. Maintain bed rest usually for 12-14 hours.
Anything else?
Instruct them to avoid straining, coughing, or heavy lifting for maybe a week or two to prevent increased intra-abdominal pressure, which could dislodge a clot at the biopsy site. The primary nursing goal here is preventing and detecting complications, especially hemorrhage.
Okay, let's bring it all back to LC. His diagnostic results came back. Hemoglobin 6.8, hematocrit 20%.
Wow, okay. Significant anemia, consistent with his report of rectal bleeding.
His WBC count, electrolytes, LFTs, urinalysis were all normal.
Okay, so liver seems okay for now. No obvious infection marker in WBC.
A CT scan was done. It revealed pockets of gas and fluid in his ascending colon and confirmed 2 medium-sized tumors in his transverse colon. And remember, the rectal exam found a palpable mass. So what does this all mean for LC, and what are the immediate nursing priorities now?
Okay, so putting all these pieces together now, what really stands out? His severe anemia, the confirmation of multiple tumors in the colon, plus that palpable rectal mass, it strongly suggests colorectal cancer as a cause of his significant GI bleeding.
And the gas and fluid. And absent bowel sounds.
Right. The gas and fluid in the ascending colon, combined with the absence of bowel sounds noted earlier in the left lower quadrant, that likely indicates a partial, maybe even near complete, bowel obstruction, probably caused by one of those tumors. This fits with his report of constipation alternating with diarrhea and not having a BM for 4 days.
So, immediate priorities.
Number 1 is stabilizing him. That severe anemia needs urgent attention, likely a blood transfusion. Managing his acute pain is critical. And then preparing him for definitive diagnosis, likely a colonoscopy once stable, to visualize and biopsy the tumors, and planning for intervention, which will likely involve surgery for both the cancer and the obstruction.
Wow. What a deep dive into the GI system, from those tiny microvilli up to the massive liver, from the complex neural networks down to the really critical nursing assessments we do. It's just so clear how interconnected and vital this system is.
It really is.
And for you, our future and current nurses listening, understanding these foundations, knowing how to assess the patient thoroughly, understanding the why behind diagnostic tests, it's truly empowering, isn't it? It lets you provide that excellent patient care.
Absolutely. And knowledge is always most valuable when you can actually understand it and apply it. This deep dive, I hope, has really highlighted the importance of a meticulous, holistic approach to GI assessment, integrating what the patient tells you their subjective report with your objective findings, recognizing those important age-related changes. Every single piece of information helps you build that complete clinical picture. It makes you a more effective and, importantly, a safer nurse.
Totally agree. And remember how we kept coming back to LC. His case really brings it to life, doesn't it? How crucial your assessment skills are in connecting those dots. From his reported symptoms, his risk factors, all the way to critical diagnostic findings like severe anemia and colon tumors causing an obstruction. It's all about thinking critically, synthesizing that information, and being ready to act.
Yeah, definitely. And this raises one last important question for you to consider as you move forward in your practice.
Yeah.
How will you make sure you integrate cultural and personal values into your GI patient assessments and their care plans? How do you promote adherence and satisfaction? Think about LC's Native American background. How might that influence his understanding, his preferences, his interaction with the healthcare system? Considering that as a key part of providing truly holistic, patient-centered nursing care.
That is an excellent thought to reflect on as you continue your studies and your practice. We really hope this deep dive has given you a clearer, more confident grasp of the gastrointestinal system. Keep that curiosity alive, keep asking questions, and keep building that amazing knowledge base. You've been listening to The Deep Dive.
And from the entire Last Minute Lecture team, thank you for joining us today.